cup of tea and they cannot hold it any longer, and it suddenly drops because of sudden loss of neurological function. In an extreme case, patients can lose consciousness if they've had, sadly, a massive stroke. And my pointer doesn't work. So why does all this matter? Well, let's look a little bit at the statistics. And this is from the Office of National Statistics, ONS, and they've looked at the causes, the commonest causes of deaths in the UK. And I have circled here where things like dementia, Alzheimer's, and cerebral vascular disease starts. You can see that in the Black Caribbean and the Black African, that Alzheimer's is the second cause of death, commonest cause of death in Black Africans, and the commonest in Black Caribbeans. Okay, and this is for males, by the way. The same goes for cerebral vascular disease, which weighs in as third in terms of death outside prostate cancer as a cause of death in Black Africans and Black Caribbeans. So it is important. The picture is no different when it comes to females, where again, Alzheimer's and dementia, as well as cerebral vascular diseases, is first and third as causes of death in this age group. Similar picture in Black Africans, okay, and both in terms of dementia and Alzheimer's disease and cerebral vascular diseases. Cerebral vascular essentially mean strokes. So with this kind of statistics in mind, these are important causes of death in our community that we do need to pay attention to, both in terms of the treatment and in terms of the prevention. Let's talk a little bit about vascular dementia. There are various types of vascular dementia, and I put this picture here just to, again, to illustrate the differences of the levels of the blood supply problem. Whereas a stroke is, as I said, occurs around there, for example, or there, vascular dementia causes blood vessel problems in those small ones at the very end of the arterial blood supply. Okay, and therefore the types of vascular dementia are divided into either multi-infarct vascular dementia, and what that means is multiple areas of the brain have died, okay, or a single large area of the brain has died, or what they call subcortical vascular dementia, which means the area that is involved is deep within the brain matter, again, as a result of small vessel disease. Now, this is a study done from a population in Oxford, and I've put it up here to illustrate a point. The point being that there is an association between strokes, mini strokes, major strokes, and subsequent development of vascular dementia. So if you look here, it's not very well colored. However, this line here is for patients who've had a transient ischemic attack, a mini stroke, right? And they've watched them over a period of years and seen who develops a dementia, be it vascular, be it Alzheimer's. And they found that in that population, if they've had a TIA, their risk of developing a dementia over a period of time is probably the order of about 10%. However, if in the same population, they had had a major stroke, okay, their risk of developing vascular dementia or any other form of dementia over a period of time of at least 5 years is in the order of about 50%. Right? So that shows the association between strokes, mini strokes, and the eventual development of vascular dementia. So who's at risk of vascular dementia? I would say it's similar to stroke, with a few other important kind of nuances. Of course, there's age, and again, vascular dementia is probably more age-related, more so than stroke. I was speaking to a colleague recently, and he said that almost everybody that he sees coming to his clinic with vascular dementia had hypertension. Other risk factors, of course, diabetes, smoking, alcohol. Interestingly, sleep apnea has been associated with vascular dementia. Sleep apnea basically refers to that when you have cessation of breathing while sleeping for a period of time. Okay, and some of you may have noted that. And the theory behind that is that there's a period when the blood supply to the brain is interrupted or paused for long periods of time. Remember, I said that the brain is exceptionally sensitive to blood supply. So there is that association. Frailty, head trauma, and atrial fibrillation. And atrial fibrillation refers to an irregular heartbeat. And the reason why that is that when the heart is beating irregularly, there is a possibility it'll be shedding little bits of clot into the brain over a prolonged period of time. And that in turn blocks those very small vessels that we're talking about, hence the risk. Normally, when you're talking about vascular dementia, you start to look at the early symptoms and the later symptoms, because you find someone who's otherwise healthy and is coherent to somebody who has difficulties with organizing and planning things, difficulties in following steps and instructions, and a slower speed of thought, and problems with concentrating. Later on, this deteriorates to inability to recall, problems with language, problems with speech, and problems with cognition in terms of handling or understanding depth. That, in time, may now lead to full-blown confusion, disorientation, memory loss, mood changes, delusions and hallucinations, and then eventually the inability to self-care. Now, as we all age, we will have some degree of memory loss. I'm always accused of losing my key and my wallet and constantly asking the children. Nonetheless, in healthy aging, it is accepted and understood that you will have a degree of slowness in thought, slowness in action, or hesitance. You may know the person, but not the name. You may pause to find words or need to be kind of reminded of certain words. But when it comes to a stage where you don't think the same, you don't do things like you used to do before, you just can't seem to get things started, then that is not what we would have said is part of healthy aging. Patients are diagnosed with vascular dementia as more of a supportive care. Yes, there are drugs that it can help, more proven for Alzheimer's rather than vascular dementia, but those drugs are still used. But the important thing is that their environment is controlled as much as possible. So little things trigger that kind of stepwise deterioration that you can sometimes see in vascular dementia. So basic things like keeping well hydrated, avoiding getting constipated, avoiding making sure you pass urine appropriately. Change of environment has to be thought through, because those are the things that cause those sudden step downs and deteriorations in normal functioning. The Immunizations are important, the flu vaccinations are important, and more recently, the COVID vaccinations are very important because whether if a patient who's at risk of vascular dementia or who has vascular dementia catches a viral infection such as COVID, even when they recover, they will most likely get a stepwise deterioration in their general health. And that can't be good. So let's talk about how you reduce the risks. And this is important because some of this is within our given to do. How do you go about reducing the risks of developing a stroke or developing vascular dementia moving forward? And as you know, I'm sure you've all seen the plausible possibilities of how we do that. There's lifestyle, there's diet, managing the health conditions, exercise, cognitive exercises, and embracing technology. Let's unpack that a little bit, okay? So, what drugs what are the roles of the drugs that we take? Because, you know, the reality is that we've got a high proportion of individuals with hypertension, a high proportion of patients with diabetes. Why do we have to take this, and what's the relevance for stroke and dementia? Statins is interesting, okay? Because remember that picture of the thickening of the walls, okay? That build up of cholesterol within the walls. The statin that one is prescribed stabilizes that thickening. And there's evidence actually that it may actually reduce it. There's certainly no magic bullet for reducing atherosclerosis, but statins definitely can stabilize it and maybe reduce the level of thickness. And that in turn may reduce the incidences of developing end organ problems. Blood pressure is one that we wrestle with, especially in the Black community. And often we have to have combination antihypertensives to control that blood pressure. But blood pressure is one of those single risk factors, as I mentioned, for both stroke and vascular dementia. And therefore, I would encourage us to take that seriously. What about aspirin and the group of drugs called the antiplatelets? Okay. There are various antiplatelets on the market. Aspirin is the most common one. There's another one called clopidogrel. And what this does, again, similar and in combination with the statin, is that it stabilizes that ulcerated plaque area, that ulcerated thickening that one has in the vessels that eventually can block off and or reduce the blood supply to the brain, to the heart. The aspirin stabilizes it. A step up from the aspirin is the anticoagulants, also called the blood thinners. There are various new generations of blood thinners around now. The traditional one, you need to have a test every week or so. Now, the new ones, you don't need to test for. Now, patients are prescribed these to stabilize the heart, especially when there's a risk of the heart rhythm being abnormal, a condition called atrial fibrillation. We mentioned this before, and the issue with this is that it does need to be controlled because it could be silently sending little clots into the brain, and that is one manifestation in later years that can manifest as vascular dementia. Of course, there are other drugs that control heart rates. And the other big risk factor, especially in our community, is diabetes. And diabetes causes early hardening and narrowing of blood vessels. There are various ways we can control diabetes. It's important that whatever level of diabetes one has, either insulin control, diet control, or drug control, that is managed as aggressively as we can. And some of that involves lifestyle. Some of that involves changing the food and the type of food or the nature of the food that we eat. But if we understand the end goal of this, then maybe it is worthwhile making those changes. This slide just shows you a little bit of what I do. And this is the operative intervention for preventing stroke. So typically patients will come and I would have had most likely a mini stroke, sometimes a minor stroke. And this is kind of removal. This is where I remove this hardening of the artery, there's narrowing bits of the artery to improve the blood supply to the brain. We know for a fact that this kind of surgery does prevent strokes. And it probably also improves what we call cognition, which is sort of language and speech and the finer ways of the things we do. I don't know whether it delays the onset of vascular dementia, but one could presume that if it reduces the incidence of strokes, it may reduce the incidence of the kind of multi-infarct or the kind of vascular dementia which is associated with strokes. But that is yet to be proven. Let's talk about lifestyle and how this actually relates to reducing our risk of stroke and vascular dementia. Now, smoking definitely has a strong association with that condition called atherosclerosis, the hardening of the artery. When you look at patients who have had or used to a Mediterranean diet, low salt, low carbohydrates, high in antioxidants, etc., there's that possibility that those set groups of individuals who probably live in Mediterranean countries do have a longer life stroke and vascular and dementia free. There is that possibility, but and some of the diets that we do have may not help us that way. And if you saw that slide that I showed from the ONS with the incidence of deaths in various populations, you probably see the higher risk of ischemic cardiac deaths in the Asian population, and that's usually because of a combination of things, diet being one of them. Exercise. Now, one cannot stress too much the effect of exercise in improving lifestyle and reducing strokes and end problems. There's a lot of physiological work that's been done that shows the increased blood supply to the brain and various organs and the benefits of exercise in our lives. And it doesn't have to be onerous exercise. You don't have to necessarily, go and lift weights in the gym. It's well prescribed exercise and something that your GP can actually prescribe for you if it's if you take him to task about that. Hydration. I think we're all we understand the importance of keeping hydrated, drinking water in hot and temperate countries is very, very important. In this country, it's equally important to drink as much water and fluids as we can. Now, this is something that I think is worthwhile talking about. Let's say you're 65 and you're retired, you've had quite a busy working life, and you now want to take it easy. That's the time not to actually slow down in terms of your brain activity. You need to take up certain things because this brain training, increasing your cerebral reserve, has been shown to reduce the onset or at least improve cognitive function in later life. Now, I'm not going to tell you that it necessarily delays or prevents vascular dementia. However, it does help because what you do have is a cerebral reserve that you can call on when those other nerve fibers start to malfunction. And, it's just the simple basic things that we can do. Cards, mental maths, puzzles, games, study, take up a new course, learn a new language. And these are all things that stimulate the brain. And if you've got grandchildren or children that, I don't do it, but then, work on their PlayStation, is interesting how much cerebral stimulation that this thing can cause. But on a more serious note, I think embracing technology perhaps just open the doors for us learning more about our health and monitoring the way we eat, our lifestyle, because medicine is now moving on to personalized care, predictive care, And I want our community to benefit from that as well. So there's a lot of information in the right place online. And I do underline and emphasize the right place online that can support the activities we do, especially in terms of improving cerebral reserve and reducing the risks of untoward, unwanted strokes and heart attacks and vascular dementia in the future. I'm going to end now by just a little word about healthy aging, and again introducing this concept that it's defined as a process of developing and maintaining the functional ability that enables us all to have well-being in older age, and that's it from the WHO. It does not mean living free of all health issues. No, a proportion of us will be hypertensive, a proportion of us will have diabetes, but it's how best do you manage this such that it gives you the quality of life in later life that you need, such that the complications of these comorbid conditions do not define who we are. Thank you very much for listening to me, and I will welcome your questions.
Thank you very much, Deji. Would you like to stop sharing your screen so that we can take some questions? Thank you. That was really detailed, which was really helpful, really. What I find is that we have a combination of really some lay people, very, very lay people. So, and then we also have people who log on, obviously, who are interested because they're either providing care or they themselves are affected. And I call people who've had a stroke sort of senior lay, because they have more understanding than people who haven't had a stroke, but are still sort of lay. So this would have been really helpful, because it's not the kind of conversation you have with your doctor, isn't it? So you might have been told you have a vascular stroke, but I don't think many doctors will have the time to sit down and actually explain the detail behind that. And nowadays people want to know. So we've had a couple of comments, and I've had some questions that have been shared directly with me. So one of the things you talked about was a syndrome, and somebody's asked me what a syndrome is, but I think because of the definitions you gave, it's just about the different types of stroke. Is that correct? Because it's not my area of expertise. I don't want to explain things if they're not correct. Is that what that means?
Yeah, I think the syndrome in this context is about a collection of symptoms that fit into that definition. So I think I tried to allude to that. So yes, you can say the different types of strokes, but what I was alluding to is the fact that it can manifest in several ways and not in the same way, and still be classified as a stroke.
Okay, so one of the things that as you alluded to, that you found really helpful is that advert on the that comes on TV, the FAST advert, face, arms, speech, and then I think T is time to dial 999, isn't it? Yeah.
Yes.
So
yes.
I've watched that as a sort of, I think in terms of stroke, I see myself as quite lay, but it's quite a useful mnemonic to have, isn't it?
Yes, absolutely. I think the government has done well there to educate us all about what to watch out for, because I guess up to that time, people wouldn't know to act on and how quickly to act. And the issue about acting is that if you have had a stroke and after a period of time, I think it's currently about an hour or so, there's certain treatments that they can't afford to give you because there are no benefits. But if you do arrive in hospital within that window of time, then you can have a treatment called a thrombolysis, which is an injection that they give you to dissolve the clot that's caused the stroke in the first instance. And there is clear benefit from that, but it's a time limited thing. And that is why, time is of the essence, because after a period of time, they may deem, the stroke physicians or the surgeons may deem that injection, that treatment is no longer suitable for that individual because of the time delay.
Okay, so the two things that we want to really take away from this presentation is, one is that essence of time. And there's no point hanging around thinking, is it not? Even if you're not sure, time is of the essence. because if you think you have a stroke and you don't present quickly enough, you may not be able to get sort of really essential treatment that you could be afforded if you had presented earlier. That's the first. And the second thing is all the things that you talked about prevention. So that's why we really value talks by consultants and GPs who come and talk to us, because all of it is that, well, if you develop it, what to do, but what we don't want is to develop it. So the couple of questions I'm going to just ask you, one was about the outcomes of vascular strokes in Black populations. Is it different in Black people because compared to other ethnic groups?
You mean the outcome of surgery or the outcome of actual strokes? The
outcome of if you have, because your expertise is in vascular strokes, yes, in that area, if you now have surgery. So if you have a vascular stroke and then you're subjected to surgery, are the outcomes worse?
I don't think there's any evidence that the outcome should be worse. I don't have that as actual data, but there's no evidence that I understand that the outcomes will be any worse. And so a lot of the data outside the US tends to be more kind of not necessarily on ethnic lines. So I don't have any evidence per se. Well, that's a very interesting question. It's something that I probably should be looking at as to whether there's any adverse outcome because on ethnic lines. If there are to be, I think the outcomes are more related to existing comorbidities and looking at things like your hypertension, how well is it controlled? Your diabetes, how well is it controlled? So in any patient, irrespective of your race, those factors leading up to surgery will be the main determinants of the outcome.
Okay, so what about just the number of people? And you showed us that ONS data, the data that you showed about how common it is in the different ethnicities.
Yeah.
I couldn't tell from that data, was it commoner in Black people? Because that was looking at all causes of death within each group. So vascular dementia on its own, is it commoner in Black people than others, or is it not? It's
common. Again, they broke it down to Black people and African Black and Caribbean Black. And yes,
I know they want to slice and dice us. We're all the same underneath, really, but
exactly. But I don't know. It's interesting. But yes, the data did show that dementia in particular is the leading cause of death in Afro-Caribbeans, Blacks, definitely, especially males. And it becomes the ONS data is the ONS data. It wouldn't break things down that way for you. But then I think it is more.
I know they don't break it down, but as a clinician, when you see people present, I suppose Chester is not the most diverse cities, but when you go to meetings and they're presenting, is there any reasons that they give why it is so much more common?
No, the explanations and the emphasis tends to be not necessarily even on the Black populations, but more on the Asian populations, where they will talk about the diet, they will still talk about the smaller vessels that they have generally, but they don't give those kind of explanations to the Afro-Caribbeans. And the other thing that data doesn't tell us is that yes, those causes of death, but what is the lifespan and the longevity? At what age are these things happening to the Blacks and Afro-Caribbeans? Is it at a relatively younger age or the same age as the Caucasian? So those are the kind of data that one has to tease out. And I think that, being in that community, that's the kind of data that we should be working towards and finding out. So and in context, i.e. in this country, not in the US, not in Africa, because I think that, first of all, if you look at it, the lifespan of an individual in, let's say, West Africa is a lot shorter than the lifespan of the individual in this country. And the causes of death are also different. So those kind of results, those kind of data and research should be done within the context of this country.
I think that's really important to stress. Faye and Charles, who are our chair and chief exec of the Caribbean African Health Network, will remember well that we went to visit an obstetrician to talk about outcomes for Black women in this country. And one of the things they told us was quite shocking, was that outcomes for Black women in this country are better than Black women in their birth countries. So I said, well, you know, for many Black women that are here, this is their birth country. So it's absolutely right to point out that we should be comparing and looking at what happens to Black people here, because this is where we live. We are, you know, British nationals, and it's important to look at that data. It's interesting what you said about looking specifically at Asian outcomes for strokes, because I suppose that sometimes it's, and this is why Caribbean African Health Network, one of the reasons why it was established, to make sure that the voice of Black people are being heard. Because if you do not raise your voice, you do not shout loud enough, looking at specific resources are not directed to looking at outcomes in a particular population. So that's really important to look at. I
think you're absolutely right there, Nozi. And the issue, I alluded to the fact that I'm very much interested into in digital health. And the importance of that is that a lot of interventions and innovations are going to be based on this data that they get and that are being used. And if that data is skewed for whatever reason towards a certain population, then we may find out the outputs are not relevant to us, or they don't work for us as Black people because they have not included us within that data set. So it is very, very important that, you know, we get data that is unique to us and that can be used for our community.
Yeah, you said one of the things you mentioned, while not just related to stroke, is about the effect of the digitization of health, which you see as the sort of way forward. You know, there's a lot of digital poverty, so that you find that people cannot access some of these things that are happening. You know, people are putting in interventions that people are having. How do you think that we can address this specifically for the Black community, who, because when you look at ONS data for poverty and income, it is skewed towards the lower end of that. And these are the same populations that will have digital poverty as well.
You're absolutely right. And that leads right into the steps of what they call the digital divide. So in the UK, they would say that they've got 80 to 95% internet coverage across the country. And so they will say that access per se is not an issue. But actually that doesn't solve the problem, because access still is an issue. You know, there are varying speed of broadbands, there are various kind of income levels to afford the right broadband and the right devices. And some of it is socioeconomic. I think that, again, you know, organizations like CAHN would need to talk at various levels because, to the policymakers, because it has to be policy driven in terms of being creative and innovative, defining what in the community is making certain people excluded from the digitization. It's not, I mean, most people have a phone, most people can get on the internet, but do they actually, or what makes them actually access healthcare on their phones? The COVID pandemic, for example, has made more people having to access that by necessity, but there's so much more that can and should be done. And that, I believe, is more, is what governments, both local and national, needs to be pushed to do for the minorities. They've identified the minorities as the predominant people in this digital exclusion, yet they need to do and put more policies and be more creative about how they include the marginalized and the ethnic minorities in reducing the digital divide.
Thank you. I think, I'm sure Charles and Faye will have something to say about that. And I know they're working really hard in the background. The other thing I just wanted to touch on, and I think it's important for people who are listening in, is that we always stress in all our talks about exercise and diet. It goes without saying that you need to live a healthy lifestyle to prevent some of these things. But at times, medicines are also important. And you touched on medicines, and most people do not like taking medicines. We see it as the last resort. I include myself in that. I would only take it if I really had to. So I know there are people here listening thinking, I really don't want to take medicines, but sometimes it's indicated. Do you want to just say a little bit about the statins that you mentioned?
So what that? Sorry, say that last bit again, Ngozi.
You talked about statins.
Yes.
Yes.
So I deliberately went to town, hopefully, to emphasize and make people understand the role of these medications and what they actually do for us. And
I must say,
I fully emphasize
that you showed. I said the live picture you showed of those vessels, in surgery, coated,
yes.
was really compelling. So if anybody doubts what can happen to the insides of your vessel, you've seen a picture here of someone who's seen that live as well.
Yes, and it wasn't meant to startle anyone or to put fear, but that is the reality, and that's what happens to us. And our diets, they are, and I think the important thing to take away is that there are things that we can do, but we can't stop aging, for example, but we can have some control as to how we age. And you alluded to exercise, absolutely. Doing those things. So, being 65 and saying, well, I retired and that's it, and I'm hitting the pub there are other things that you can do to make sure that you are still able and willing at the age of 75, 85, 95. And if that means, taking the statins to reduce that cholesterol buildup, as well as modifying your diet, for a lot of us, that is within our givings to do. But like you said, Ngozi, no one likes taking tablets, and I'm always forced to go to the gym if I could do that at all. But we know these are the things that are very, very important, and I think we should encourage each other to have those kind of change in paradigm, change in mindsets, so that we are better performing as an ethnic group.
Well, thank you so much for your presentation, for the questions that have followed. You've been really clear, and I think that whoever's dialed in today will be able to take something away from today. And we're really sorry for the late start, but I think we've managed to get through everything. So thank you. I'm going to hand over to somebody from the Caribbean African Health Network team to just do some closing comments.
Thank you, Ngozi. Thank you, everybody.
Yeah, thanks, Ngozi, for hosting. Thanks to Dr. Deji for, coming along and presenting with such clarity. If it's okay, we will need to rerun this because there were quite a number of people who couldn't join because of the change in Zoom details. So, apologies to everyone once again for the late start. We will, speak to Dr. Deji and try and rerun this in the new year. But, massive thanks, everyone, for those who may be wondering how to take the first step when it comes to your diet and physical activity. Then every Tuesday evening between 5:30 and 7:30, there's a one-to-one session for that nutrition, and we do have a nutritionist who will, support people on a one-to-one basis between 5:30 and 7 o'clock. And then last 30 minutes we use for physical activity. So just to say massive thanks, everyone. The recording, and hopefully we can get the slides from Dr. Deji, and happy to share that or put that on our website and people can download. But once again, massive thanks, everyone. And apologies. Hopefully from next week, we'll revert back to the usual, Health Hour joining link. Have a wonderful weekend. Take care of yourself, and we will see you on Tuesday. Bye.
Bye.
CAHN Health Hour. Giving back health advice. Get informed today to have a better, healthy tomorrow.